Hi everyone, I'm back on the topic long QT syndrome. Today we'll be talking about diagnosis and treatment. If you have not listened to the first presentation on long QT syndrome, I would advise that you do because you may not understand everything we'll be talking about here. We have presented long QT syndrome, the causes, the clinical features, the acquired and congenital ones. Now we want to talk about diagnosis and treatment. Let's go. It is worthy to note that though we have gallons of medications, lots of them that are causing trouble or actually worsening long QT syndrome in those who are congenitally predisposed, but here is the good news. Beta blockers are actually protective. Beta blockers are actually protective. But you can't just assume that you have long QT syndrome and go to store. It's not over-the-counter medication, so still need to go to a physician. Make sure you are diagnosed or you are not. Then he or she will be able to guide you. So how do you make the diagnosis of this trouble? EKG. EKG. Mostly routine EKG is going to pick that. Some people will just walk into the office of the doctor for other reasons, maybe for insurance, for sports, for anything that requires EKG, and that is the time most people will be diagnosed because it is asymptomatic when there is no total point involved yet. So, like for sports, or somebody in the family has been diagnosed with it, then you are prompted to have yourself checked up. And they run the 12-lead EKG, lo and behold, you have it. In sensorinueral deafness, like I've mentioned that in my first presentation, you have to check it out. Run 12-lead EKG in that individual who has been diagnosed with sensorinueral deafness. Why? He or she may be having long QT syndrome as well. If there is seizure disorder in this person and you have tried to rule out every possible causes of seizure disorder, and you are about coning down on idiopathy, or this, you say, okay, this is of unknown origin. Before that label, check out with 12-lead EKG. You might actually be living with long QT syndrome. 12-lead EKG and try to study all the leads. Try to study all the leads, but focus more on leads 2 and V5. The QT interval that I have put up here, you read the small boxes between the onset of Q and the end of T. I'm sorry that I'm not a good artist, so I've decided to put this little sketch up to represent the waves. You send the P wave, the Q, the R, the S, and T. So it's the beginning of the Q to the end of T. And you count the small boxes in between those two waves, the beginning of depolarization to the end of repolarization. So it's essentially ventricular problem. We are still on diagnosis. We have done the EKG and we are going to go to lab. Laboratory for what? Toxicology. Why? So many medications and street drugs are involved. So let them screen everything that you could screen out, including cocaine. And We are in the lab right now for electrolytes. Hypomagnesemia, hypokalemia, hypocalcemia. Let's know what is happening, because low level of magnesium could lead to sudden cardiac death from long QT syndrome, polymorphic ventricular tachycardia, or to side point, ventricular fibrillation, pace systole. Let's check what is happening to the kidney, renal function test, because that will affect the electrolyte law. Cardiac enzymes, let's rule out and make sure the heart is working well and there's no myocardial infarction here, because that is an example of concomitant morbidity that could prolong the QT interval. Genetic screening, you cannot just ignore that. Like I've said in my first presentation on long QT syndrome, some that are having the acquired long QT syndrome are actually predisposed initially, but unknown to them, and now when they are on those medications, as common medications as antibiotics like erythromycin or zithromycin, and they are now coming down with problem, or they are just on antidiarrheal like loperamide that everybody is taking everywhere, or antiemetics, on the Centrum that a lot of people have taken every day, and now they're coming down with this, then you begin to suspect what's happening in their family and do genetic screening. And even with genetic screening, you might be able to get the family ahead of time so that they could avoid what they could avoid. Treatment. This is not a joke. We admit. Check the airway, foreign body, or secretion, and treat as appropriate, including removing that or suctioning as the case may be. Check the breathing. Is this person's nose? Is in any respiratory distress? Chest deformity, chest moving respiration, no flaring of velar nasal accessory muscles being used for cause for dullness or consolidation, auscultate, count the respiratory rate, do everything that you need to do. Circulatory system, the volume status, dehydrated or not, what is the BP here, what is the heart rate saying, fluid in and out. Now just do that and ask the good people, the nurses, for the vital signs. Then, of course, put your fluid up as may be appropriate. You give oxygen if the O2 sat is below the recommended level for this age. Check that. Now, determine the stability of this person. In other words, is this hemodynamically stable individual or hemodynamically unstable individual? And the blood pressure level, the heart rate, confusion or not, will let you know if this individual is stable or not. So if the person is unstable, please, no grammar, electrical cardioversion right away. And you hook up the cardiac monitoring, 12 lead EKG, and stop any offending drug or drugs that you know of. Then correct metabolic anomalies like electrolyte imbalance. If there is hypomagnesemia, give magnesium sulfate. And if there's hypokalemia, you know what to give, potassium chloride. And correct the acidosis as arterial blood gases may reveal. So in other words, do arterial blood gas. We are still treating. To certain point, due to long QT syndrome, treatment may be essentially no treatment. Why? To certain point, most of the time would terminate spontaneously. So it's self-limiting most of the time. And that is why many people with long QT syndrome are not diagnosed. So when they have to the point and they have symptoms, the symptom will disappear spontaneously on its own, even before thinking of calling the doctor or going to the clinic or calling emergency people. But that is not all the time. That is not the case all the time. But those who have congenital long QTs, beta blockers will help, mesalazine will help. Yes, we are still on treatment. Magnesium sulfate if there's hypomagnesemia, sodium bicarbonate if there's acidosis, isoproterenol, lidocaine, phenytoin, and of course temporary atrial pacing or temporary ventricular pacing. The treatment may be non-pharmacologic in nature with permanent dual chamber pacemaker. Why? Because I've told you from long QT syndrome to polymorphic ventricular tachycardia to ventricular fibrillation and to asystole. So you want that to be checked and put in order without necessarily having to go to the doctor all the time. So they put permanent dual chamber pacemaker and cardiothoracic sympathectomy or implantable cardiovascular defibrillator to defibrillate ventricular fibrillation. In conclusion, now I've reached the end of the journey as far as long QT syndrome is concerned. Like I said, while rounding up the first time, it is truly long. So now it's about 36 minutes the first time with an additional 12 minutes plus right now. How I wish that all newborn will have EKG at birth. And this is a noble call to those who have the powers to influence policies that 12-lead EKG should be included on the list of screening tools for all newborns, because we don't know those kids who have it and who might die suddenly and we attribute it sudden infant death syndrome. Part of it could be long QT syndrome, not ever diagnosed. And many people have sudden cardiac death because they didn't know they are long QT syndrome. And some who are genetically predisposed will not be able to guard against triggers. And imagine even sleep apnea. And the individual is on CPAP and everything like that, not knowing they have long QT syndrome. So many people are having this problem across the globe, but no diagnosis, and they are dying. They are dying because they are taking medications that could worsen the situation for them, not the fault of their doctors, not the fault of the pharmacist, but not even their own fault, but because the EKG is not run, and EKG is not run because it's not routinely done. But if we will shy away from that and take up the responsibility that anyone with the family history should be, having free checkup with EKG, maybe more EKG machines will be manufactured worldwide, and good government will take up that responsibility for everybody to check all newborns worldwide. I'm truly wishing all affected people well. Thank you for listening to my presentation, and kindly subscribe so that you can get my presentations immediately they are published. I appreciate it. Thank you.